Hey, good morning, everybody. I'm Robert. I'm the security director here at Duke University Hospital. I started in November of, or excuse me, October of last year. Excuse me, not of last year, of 2019. So I'm glad to be here at Duke. I came from Mission Health in Asheville, and conflict communication, also known as de-escalation, is kind of my thing. I teach it outside of work as well as, of course, here in the health system.
And the addition of Robert to our team a year and a half ago has been a fantastic addition. He has partnered and really taken us to the next level as we try to understand how to deal with disruptive patients. And I know that's a particular issue in your line of work. We actually see this in every specialty, disruptive patients and visitors, not just relegated, I know, to the psychiatric emergency room, but also to our floors on general medicine, sadly in pediatrics even. And so we really had to develop a more standardized way to deal with this. So appreciate the chance to walk you through that. I'm going to spend a few minutes talking about our university hospital approach to disruptive patients and visitors, and then really hand it off to Robert, whose gift is really talking about how you de-escalate situations so that they're less threatening to you and create a calmer work environment, and so that you leave here today with a few tools in your belt to help you to deal with that next difficult situation you walk into. So from a hospital standpoint, back in 2018, we noticed and spent a great deal of time looking at the Joint Commission Sentinel Event Alert 59. And it really began to help us to formulate that physical and verbal violence against healthcare workers should not be tolerated. We've seen verbal abuse here, some physical abuse, and we've heard of even deaths of healthcare workers at other institutions related to the disruptive behavior of visitors and patients. And so we formed a task force to look critically at our approaches to this. I don't know why I don't know if you can see it. There we go. Looking critically at our approach to our disruptive patients and visitors. And one component of this was the ability to really clearly identify someone that you found to be disruptive, or a visitor of the patient you found to be disruptive, so that the next person understands that and can safely approach the patient. Sorry, I'm having trouble advancing my slides. There we go. Sorry. One way that we chose to do this was through our quality management system. And as you know, the Duke Health system has really transitioned the way we manage quality to focusing on real-time escalation of problems. So in this setting, a real-time escalation of a disruptive patient or visitor. But this really relies upon having transparency in the data so that everyone can see that there's been a disruptive event or a disruptive patient or visitor, and to rapidly deal with that so that the next person isn't harmed by the potential for injury. And our goal is zero harm. So we know that there's zero harm to our patients. I mean, that's why we are in medicine. We're here to get our patients better and have zero harm to them from infections or falls, pressure injuries. We know we want zero harm to their loved ones. We don't want them to slip in a hallway. But how do we think about zero harm to each other? Because that's part of our mission, is to protect each other. And what tools do we have to prevent harm to our team members? And with the knowledge, and this is, I feel like we need to say this out loud, the patient satisfaction does not override patient safety, not override staff safety. Patient satisfaction is very important. We want our patients and their loved ones to have a good experience, but it should never be at the expense of the emotional or physical safety of our team members. So we put together a policy after that task force was put together to deal with the disruptive behavior by patients, their loved ones or family members, or visitors to our institution. We want to encourage the best possible care for our patients and their families, but to have a safe and healthy work environment. We can provide a link to this so you can get on and understand this whole policy if you're interested. But I really want to highlight a few key points so that when you look at the electronic medical record, you can understand if a patient has displayed disruptive behavior. So if you look at our electronic medical record, you can see a lavender banner. And I have to say, in the last iteration of changes, it looks just a slight different from this. But you'll see a lavender violet banner across the top of a chart of a patient who has displayed disruptive behavior or whose consistent visitor has displayed disruptive behavior. And this is a color that's being used in many places across the country, and particularly in Children's Hospital. And it helps you to remember violet for violent. And so if you look at the patients who have that banner across, it's nice to know that they have displayed disruptive behavior, but what are you going to do with that information? Well, the important thing is to look at this FYI, to look at the information available, because it's not enough to just say, well, this person's violent, don't go check on them. We don't want that, but we want you to know how to safely approach that patient. So if you have a patient that's displayed disruptive behavior, you need to gather your clinical team together, and that includes nursing, the APP resident, faculty member on that team, on taking care of that patient, security, maybe our operations administrator, and say, how can we best safely approach this patient? Is it by only going into the room when the door is open? Is it by having standardized words that if they use inappropriate language, you're simply not going to care for them at that time and you'll return later to take care of them? Or is it that you'll always take another team member in with you to provide care to this patient? It also includes things like, you want to be between the patient and the door. You don't want to be on the other side of the bed if you can possibly help it. And if you do, you need to take someone in with you. This allows us to know throughout the patient's care that there's something that you should do extra to maintain your personal safety. This is available as a banner here. And if you look on a patient list, it shows up as a purple dot. It's visible to everybody who has access to our electronic medical record. So in other words, if that patient is being transported from one place to another, the transport team member on their ticket to ride will have a purple dot on that. So they too will know to pay extra attention to their safety. And this purple banner follows the patient, as it were, throughout, so that if they're discharged and they return to your clinic, you will see on your clinic schedule for that day a purple dot, and you'll know to exercise extra care in approaching that patient. It isn't removed until we remove it. And it can only take place by risk management or our operations administrator. So it can be done 24 hours a day, but not everybody can apply it because we want to have some rigor to how we manage that and how we keep everybody safe. So I want to talk a little bit about how we get to that point. We talked about gathering your team members, about coming up with a plan, about documenting that. And one thing I want to, before we transition to de-escalation techniques, is talk a little bit about, everybody's afraid of putting something in the electronic medical record that might be more about patient behavior than about their medical condition. But I want to encourage you that documenting a patient's behavior or their family's behavior is absolutely okay. In fact, we appreciate that because if you think about the way that we take actions, say a visitor who's been disruptive repeatedly, and we trespass them from the hospital, and you look back in the chart and there's no documentation at any point in time that that visitor was disruptive or that the patient was disruptive, then there's no sort of evidence for why we acted the way we did. And no one else is clued into that. Then when our state or national visitors come, Joint Commission or DHSR come to visit us, they say, why did you dismiss this patient from your clinic? Why did you trespass that visitor? There's no evidence that anything occurred here. And so in a very unbiased and unemotional way, documenting some behavior in a clinic note and then in the FYI flag so people know what to do for safety is absolutely appropriate. And if you're not sure about what to do or how to do that, it's completely fine to escalate that to a senior member of the team or to call risk management and say, this was the situation and I want to put the right thing in the chart, and they will absolutely partner with you. For your information, risk managers are on call 24 hours a day. They aren't in the hospital 24 hours a day, but they're on call. So if you're in a particularly difficult situation, there's always leadership that's available to support you. And that information can be helped to drive the care of the patient safely, and then also to inform the next team member that comes in. So I really want to encourage you to talk about behavioral issues, to document them. But then I want to hand off to Robert too, because as we all know, a disruptive behavior sometimes is simply a patient who's scared or a family member who's upset about some news. And sometimes the way that we interact with that patient or visitor or even another team member can make a difference between escalating the situation to where emotions are higher and higher and higher and become a blow up, and de-escalating the situation into providing support for the team and keeping everybody safe. But the key is, how do you do that? So I'm going to hand off to Robert, who's going to talk a little bit about de-escalation techniques. We can absolutely save time for questions. I did sort of make up a couple of cases that would be relevant to your patient population at the end if we want to talk through those. But if you have real-time cases that would be better to discuss than those cases, that would be excellent. And Robert, I have control of the slides, so you can just take over and I'll advance the slides as you asked me to.
Okay, thank you, Dr. Pickett. So you just mentioned several things that I'll just piggyback on, the documentation part. When we train staff in de-escalating, we always encourage them to let their de-escalation efforts essentially write their reports. So if you come away from this with 2 or 3 principles of de-escalation, that really is all we need in the notes to help us do various actions, such as trespass a patient from the hospital or trespass a visitor. You simply document the behavior and you document what you did in response to it. And it really is as simple as that. So this first slide really captures the principle that de-escalation really falls, according to me at least, into 2 main buckets. We've got create a calm atmosphere. That's what most people think of when they hear the word de-escalation. This relates to strategies and methods of generating voluntary compliance in everyone that we are working with. This includes our employees. Generating in others their voluntary compliance, cooperation, or collaboration. We want people to work with us. We don't want to have to force people to do things, because many times we cannot force them to do things. And when we have to force things, such as place someone in medically approved restraints because they're being violent, it just increases the chances that someone's going to get hurt. So creating a calm atmosphere is everything from talking politely to people to showing them dignity and respect, to light and noise discipline in whatever patient care area we're dealing with. The other area, the other bucket is what I call the stay safe bucket, which we should always marry to the creating a calm atmosphere. Whenever we're de-escalating, we should always keep part of our awareness on staying physically safe. So as I think Dr. Pickett made a reference to, we should always be careful when we go into rooms. We should always have an exit strategy, whatever we're doing. And this should be a kind of a calm, non-paranoid kind of awareness. We shouldn't be scared every day, but we should just have an awareness on creating a non-escalating environment, which we'll go into a few principles of how to do that, all the while remaining aware that we may need to exit or run from a scene if we have to. But again, de-escalation is really about creating an atmosphere with others where they're going to voluntarily work with us. That's the whole premise of it. De-escalation does very much double as a customer service program. Probably the distinguishing feature as I teach it is that it's about staying physically safe. You can go to the next slide, Dr. Pickett, please. Okay, these are just some of the benefits of being skilled in de-escalation. I would highlight, however, that the #1 reason that we do it is personal safety. And that's what we should encourage staff when we're helping them with de-escalation. It's all about staying physically safe. These other benefits are kind of, you might even call them side effects of de-escalation. They're very valuable. You know, decreasing injury rates is exceptionally valuable. Decreasing the chances of getting complaints or being sued is exceptionally valuable. However, the number one reason for doing de-escalation is personal safety. Notice the two things at the bottom, and they're not ranked at the bottom. They just happen to be positioned there. Less stress, fear, and increased staff morale. That's what frontline staff will leave every day with. Frontline staff will quickly get tired of being overly stressed every day by being put in situations where they have to deal with people who are agitated and difficult to deal with when we give them no skills to deal with that. We will increase our employee retention if we give staff more de-escalation skills. Staff simply go home more happy every day. That was my phone ringing there. I'll get that later. Okay, you can go to the next slide. So I think we skipped one. Was there one more before that? What's the next one? I'm looking for the premier 5-minute method. Is that in there, Dr. Pickett? It looked like it got left out. Okay, we'll go back to the next slide. Let me just speak to what I call my premier 5-minute method. In de-escalation, no technique, tactic, method, strategy of any kind will work unless dignity and respect are in the communication atmosphere with you and the other person. Again, I cannot say this strongly enough. If we're not showing the other person dignity and respect in our communication, no technique or tactic will suffice to keep us safe. I was asked by an administrator in my prior organization once to present to his leadership team on de-escalation. And I said, how long do I have? And he said, 5 minutes. And I said, well, okay, that's great. 5 minutes, I can scratch the surface. Well, this is what I shared with him. I shared about dignity and respect. I got feedback from at least one of the participants in that audience that seemed kind of warm and fuzzy. And, you know, he was kind of being dismissive of the value of dignity and respect. And I had to explain to him and the audience that it's really not about being warm and fuzzy. It's not about being nice. Those things happen. When we show people respect, we actually create a non-escalating environment with them, and we actually keep them calmer and less likely to get agitated. We know in American parlance, we have the term to diss someone, and that's a very technical term. For some people, it means to treat someone in such a way that they will respond with anger and for some with violence. So treating people with dignity and respect is a major key, probably the major key, the central key to all good conflict communication. So I can't emphasize that enough. So this slide here touches on another major principle within conflict communication, and that is the harmony of communication. By harmony, I mean, notice those three slices of pie. We've got words, tone of voice, and nonverbal. Most people place a lot of importance on the words, and they are important. We have a concept we call precision word choice. Our words do matter. However, they don't matter, especially when we're in a disagreement or we're trying to persuade someone to do something they don't want to do. They don't matter as much as we think. This is a chart we use in verbal judo, which, by the way, I should have mentioned that early on. What I teach is rooted in the discipline of verbal judo, which some of you may know. It was made popular in American law enforcement back in the 80s. And it's, according to me, it's the gold standard of de-escalation, and it's been tried and tested on in law enforcement in the streets of America. And if it can work there, it can work here. So this is what this is based on. Notice the tiny a slice of pie for words, 7%. Now, this doesn't mean words don't matter. They do. However, tone of voice and body language matter a lot more when people are communicating with us, especially in a moment of conflict, whether it's minor or major. When we say something to someone and our tone of voice does not match, people are going to leave with the tone of voice. They're not going to listen to the words. In fact, it's with tone of voice that we communicate condescension or a patronizing tone to someone or disrespect. So tone of voice is really, really huge. What we call in verbal judo, that our delivery style is made up of nonverbal and tone of voice. That's the bulk of our delivery style, and that's what we should really focus on. Nonverbal really refers to all the ways that we use our body to communicate with people, such as when we get agitated with someone, when we get flustered or frustrated with someone, we have to monitor ourselves so that we don't end up putting our hands on our hips, for instance, while we talk to them, or we don't wag the parental finger in their face, which can come out, almost accidentally. This is huge. I often ask people, who do you think reads body language better, men or women? We don't really have time for Q&A for that now, but I would argue that women do an exceptional job, and I don't know why. This is just my personal observation at reading body language. And if that's the case in healthcare, we've got a huge population of female staff who once they get kind of turned on to de-escalation, could dramatically increase their personal safety by reading body language, the body language of our patients and visitors. You can go to the next slide, please, Dr. Pickett. Okay, so this slide really refers to what in verbal judo we called it the 5-step hard style. I don't know why the creator of verbal judo called it that, but in another program, it's called the persuasion sequence. It's how we persuade people to do what we need them to do. It's how we generate in others their voluntary compliance, cooperation, or collaboration. This is a formula that my staff use every day when we go to patient interventions, and they've memorized it and they enact it in the moment, improvising and adapting it to every single situation. If you only took, for example, the first 2 elements of it, those are 2 major keys to dealing with people and de-escalating them. Ask, don't tell. In de-escalation, really in life in general and communication in general, this is a solid principle. We should always ask people to do something and not tell them. Now, this was something hard for some people in law enforcement, for instance, to accept, because they like to tell people what to do and they can tell them what to do. However, good communication is based on what we should do and not necessarily what we can do. And so I would encourage everyone, particularly people in positions of authority, to consider number 1 pretty strongly, because some of us may be in a habit of perhaps telling people what to do instead of asking them what to do, but it's just not as effective if we want people to voluntarily work with us, and if we want our communication to be as smooth and conflict-free as possible. This also is a solid principle for parenting. It's a solid principle for leadership. I've used this as a leadership principle for well over 3 decades now. Number 2, and explain why. We know people want to know why. I think the issue is sometimes staff maybe forget to tell people why, or maybe they hesitate and they leave the why for 5 minutes later, which gives the person 5 minutes to ruminate on what they're uncomfortable about the situation. I always tell people, let's beat them to the why. Let's tell people why we're asking them to do something. And this is as simple as telling them what's next to expect in the process. It's also especially telling them why we're having to do something that they may not like. This is exceptionally important, particularly for Americans. Americans want to know why, and people deserve to know why. I know from personal experience that when the why is missing, or if it's kind of somewhat fabricated and we're not being as transparent as we can with people, that this generates escalation in people. And we should really focus on the why. Notice number 3, give options. Everyone wants options instead of threats. And we should give people options when we're trying to persuade them to do something. Using empathy, not sympathy, empathy, looking through the eyes of the person we're talking to, giving options is really options that should appeal to the person, not necessarily to us. So when we're dealing with people, it's important to look through that person's eyes and just think through what's important to them. And as we're asking them to do something and they're pushing back on us, we should use options that may not be important to us, but they probably would be important to them. So that's important when we think about that. Before we leave this slide, I'd like to go back. When we're dealing with someone in a moment of conflict, even before we get to this formula of persuasion, we should do what we call our meet and greet, which is simply letting people know our name. It's really just that. They don't need to know our last name necessarily, but they should know our first name. This is a huge principle of de-escalation because it personalizes our connection with other people. We should let them know our name, our role, why we're talking to them. It's as simple as that. Some people do this naturally, and that's okay, but the problem is not everyone does it naturally. And so we should train staff to do it. We should remind them to do it. It's something that takes some work because I work every day in my own department to make sure that my staff let people know their name. Now, of course, I'm not talking about something that interferes with personal safety. If something is hot and it's already unfolding, then we may have to give our name after the incident. But I'm talking about most encounters. We should give people our name. Also, after we get done talking with someone and we're about to conclude the conversation or the discussion or the communication, we should, so to speak, dust them off. If we had to do something somewhat uncomfortable with the person, like we had to trespass him, for instance, we should, as much as possible, leave them in a position better than we found them. Now, they may not be happy, but that's okay. What I'm talking about is something over which we have control, such as thanking them for their cooperation. I caution staff not to say things like, have a good day, after we've had to do something uncomfortable, because that can sound a little snarky, but we can thank people for their cooperation. And that just acknowledges that, you're not necessarily, happy with what we had to do, but you understand why we had to do it because we told you why. And I'm showing you respect all through the duration of the encounter. Anybody get any questions on this? I would go further into it, but I want to make sure and capture all of our slides. But just those 1 through 3, those principles will dramatically help you in any encounter. These are principle based, so you can apply them to any discussion you have. And by the way, de-escalation is very, very valuable and just as effective on the phone as it is live in person. There's no difference except that you don't have the value of body language over the phone. Okay, let's go to the next one. So is the situation awareness slide coming up next?
Yeah, sorry, I'm having trouble advancing the slides.
That's all right. That's all right. Earlier I spoke about how we should always keep an awareness to stay safe while we are de-escalating. There's many situations, and some people may even have them in their mind right now about people who got hurt while talking to people. This is the premier way to handle any threat. This is situational awareness. This is a classic color-coded depiction of situation awareness. Some of you on the call now may be involved with hobbies that involve perhaps combative disciplines or handgunning or, sport things. And some of you may be familiar with this model through this. This was created by a man named Jeff Cooper back many decades ago. Notice the block at the bottom, tuned out. That tuned out, unaware surroundings. The FBI actually calls this mental state the victim state. Now, this is not victim blaming, but this is highlighting the fact that when we're tuned out, we're unaware of our surroundings. We have our face buried in our cell phone. We're not going to notice threats in our environment. And the threats in the environment can be a patient escalating, or they can be an active shooter in your personal life out in a marketplace. It could be anything. We don't want to be in the white zone. We want to be in that next block up, that yellow, that relaxed, cautious awareness. In my world, we call this living in yellow, and it's simply that, relaxed, cautious awareness. We should be in yellow anytime we're awake. The only time we're not in a relaxed awareness of our environment is when we're at home asleep with the doors locked. This is something that we can carry around with us every day. In some circles, this might be called mindfulness. It's simply paying attention to your environment. Notice that next block up, that focused awareness. Say if you're out in the environment and you've got a yellow state of mind, you're just naturally in a relaxed way noticing your environment, and then you notice something doesn't look right. You see something, you hear something, and it catches your awareness. That's what that orange block kind of signifies. And it's right then that you would be paying more attention to whatever that potential threat you're noticing. And if it ends up being an actual threat and it quickly unfurls to something that on which you've got to respond, that's what that next block up, that high alert, that's where you're actively responding to whatever threat that may be. And that top zone, that comatose, in shock, unable to function, that is blind panic. That is a state we don't really want to be in, but which can happen if we never think about this stuff, if we never create a plan. That can happen. Quick example, I was in a store once, or actually I was in the parking lot, and I saw an elderly lady exit the store. The moment she exited the store, I saw her notice a man who was on the tree line next to the large outlet. The man wasn't really doing much, but to her, he looked threatening. He was kind of sketchy looking. He was doing something with a buggy, and he was moving kind of slowly. But I see him, and then I saw her speed up going to her car. She clearly was in relaxed awareness the moment she came out of the store. When she noticed this man, which was kind of signified by that orange block, that focused awareness, she actually did something which to her made her safer, which was to move faster to her car, put her groceries in her car, and lock her door and leave. That's an example of situational awareness. If you take any good self-preservation, self-protection course, this, and not the punches and kicks and blocks and all that, this is what will keep you safe. This is the best tactic for personal safety. There really is nothing better. Jeff Cooper, the creator of this model, it was attributed to him. He said, safety is something that happens in your head, not something you hold in your hands. Now, this was a man who made his living from military and law enforcement disciplines. He played with guns a lot. And this man said that safety is something that happens in your head, not something you hold in your hands. He recognized the importance that staying safe is about paying attention. And with that in mind, let's go to the next slide. With no hesitation and keeping that situational awareness in mind, let's talk a moment about early intervention. We should be paying attention to our patients, and not just from a medical point of view, but from a behavioral point of view. We should be looking for what's called gateway behaviors. A gateway behavior is simply a low-level volatile behavior that lets us know a patient is changing, they're escalating. Now, this is as simple as this. Think of a loved one, and think of how he or she changes when they become more agitated, angry, bothered, anxious, upset. Think of that loved one and to yourself, note how they change. And everyone will have many different examples. Common ones include they start pacing, their breathing changes, their face turns red, their face changes. They start wringing their hands. They start moving their hands. They're moving their hands through their hair. They get louder. They get more quiet. So it's a beautiful thing about human beings that anxiety manifests physically because we can see it and we can note it, and we should be doing that with our patients. Quick example, which happens actually all the time. 30 minutes ago, a patient threw a magazine across the room. 15 minutes ago, that patient got up in the face of another patient and was screaming obscenities. 10 minutes ago, that patient got up in the face of a staff member with balled up fists and made explicit threats. 1 minute ago, that patient assaulted a staff member. Now, almost all violence has those pre-incident buildup indicators. Violence very seldom happens out of nowhere, even though you will commonly hear that like it came out of nowhere. Most violence does not come out of nowhere. The FBI notes that ambush violence, and this includes patients, as well as things like perpetrators like active shooters, they don't happen out of nowhere. There's a building up process. Think of a pressure cooker. It's somewhat analogous to that. So gateway behaviors are early signs that patients are changing, and we should be intervening as early in the process as possible to try to stop that final moment of violence, which is what we call violence. It's the assault. The assault really is just the end point of a cycle where the pressure built up so much in that person that they then couldn't manage their behavior any longer, and they assaulted someone. If possible, we should be intervening as early as possible in the process to stop the violence, and we can. Unfortunately, there's some common thinking that violence just happens and we can't do anything about it, but we can do a lot more than we think we can to minimize those physically violent moments. Just last night, Marianne Zabritsky with accreditation sent out an email about a new Joint Commission standards review, and it highlighted again that in healthcare, healthcare workers are 20% more likely to be assaulted than anybody else in the American workforce. So this is really important stuff to be paying attention to. Nurses are more likely to be assaulted than virtually anyone else in healthcare, and there's reasons for that, mainly because they're front line. They're more likely to be assaulted even than my staff, because my staff come in as support, and nurses are with these patients all the time. So this is really important to remember. Early intervention also relates to calling for help early. I always tell people, I would rather you call me and my team and be wrong than to not call and be right. And by that, I mean, staff will sometimes try kind of second guess themselves because they want to think that the patient's going to calm down, and they may, but that's okay. Call us. If we show up and nothing's happening, that's fine. We'll go 10-8. That's not a problem. We don't mind. I would rather you call us and that happen than to hesitate and call us kind of after the assault has happened. We're always there to support your staff with help. Questions about this or comments? Okay, let's go to the next slide, which I think, yeah, we're coming up to those.
There's one question in the chat, Robert,
yes.
that if you could address. What does it mean to trespass someone from the hospital?
Yeah, good question. Well, we try not to, but and when we do, it's always a interdepartmental, interdisciplinary decision. It's not a DUPD decision, although sometimes it can be, but most of the time in the hospital, it's the department leaders, the charge nurses, administrators like Dr. Pickett, and risk management. And if we cannot generate in that person their voluntary compliance, cooperation, or collaboration with us, and we cannot reach a point where things can be safe for everyone, then we're going to issue that person a trespass, and that means that they're not allowed on hospital property unless they need to come here for emergency medical care. Now, there's always nuances to this. Let's say if they have a loved one in the hospital, and particularly if there's end of life issues, there will be exceptions made where, for example, let's say if someone's been trespassed, but they have a loved one that it would be good for them to visit. We, DUPD, will meet them, escort them in, manage the visit, and escort them back out. We do those things occasionally, but it essentially means they're not allowed on hospital property. We give them a document that states such. And does that answer your question?
Go
ahead.
I think that answers the question. And I think a corollary question that I'm going to proactively answer from a provider standpoint is, can patients be trespassed or can patients be dismissed? So we sometimes, if a patient has displayed disruptive behavior or had violence in the past, we can dismiss them from our clinics. We can decline to see them in our outpatient ambulatory settings. However, on the basis of EMTALA, if they present with an emergency medical condition to our emergency department, no matter how violent the patient or whatever they've done in the past, we of course are required to see them and stabilize their acute medical needs. And sometimes that requires admitting them. And the key here is making sure that we have a safety security plan when that patient is admitted. So we can trespass. It's actually easier for the visitors because we can ask them to leave. We aren't required to have them here. We can dismiss patients from our clinics, but we will sometimes go ahead and have to see patients in the emergency department and admit them to our hospital if they have an acute medical need. And so I sort of wanted to make that division between where we are with patients so that we honor taking care of them. But we can absolutely do that in a safe way. I see a chat up here. Let's see if there's an additional question. Wow, I cannot get it to come up. Let me let you go ahead, Robert, okay. And I'm trying to I am battling my computer today, trying to see what the chat question is, and okay. I can't seem to do it.
Well, I'll go forward with this final slide. So remember, we started with the create a calm atmosphere, and we've talked a good bit about that, about how to deal with people. This is the stay safe part. And by the way, we're just touching this morning on we're just scratching the surface of de-escalation. So for some of you wondering, is there more? There certainly is more. These are simply some major pillars. So when we're dealing with people, anytime, but particularly when we're dealing with difficult people, we should manage our personal space. This is a huge, important item when it comes to minimizing physical assault. People cannot assault us if they cannot reach us. We should, as much as possible, keep a reactionary gap between us and other people, and particularly the people that we're talking about who are difficult, and particularly the ones who are, threatening or seem to be threatening. A good working definition of personal space is arm's length distance, or 3 feet-ish, the ish part being important, or whatever you want it to be. Again, arm's length distance, which is really minimal that we need, 3 feet-ish, or whatever you want it to be. Whenever I talk with people, and it doesn't really matter, it doesn't matter who it is really, I keep a reactionary gap. For me, I tend to even have a larger one. It's just from habit over many years. This allows us to have a conversation with people, but stay safe at the same time if they become escalated relatively quickly, and they may reach for us or try to strike us. Related to that is the bladed stance and the fence. Whenever we're dealing with someone who we're getting a bad feeling about, we get a gut twitch about that this person may be dangerous, we should ideally stand in some kind of a bladed stance. Now, this is taught in the programs that our frontline staff receive. It's called CPI. Our emergency department received that training. Security has it. Sarah Emery does a fantastic job of delivering this training system-wide. but it should be a bladed stance, which is simply one foot in front of the other and your body angled at about a 45-degree angle to the person. I stand like this naturally all the time. When we stand like this, we minimize our body profile. We make ourselves smaller to the person because we are not standing frontally to them. We protect our centerline targets, such as our eyes, our solar plexus, our groin. And our fence is really our hands up in front of us. Now, this can be done in a very natural way where we simply talk with our hands up. I talk with my hands, and I've almost always got coffee in one hand and a cell phone in the other. And it's not, you're not standing there like a statue. You're natural. No one's going to notice. But if someone becomes physically violent, it's exceptionally valuable to have your hands up between you and the other person to help shield yourself. That's exceptionally valuable. Notice it says make, break eye contact. All that means is to leverage your eye contact to foster good, healthy, rapport building communication with others, but making sure you're not staring. That's all that means. Leverage your eye contact and use it to communicate. Some people say, well, I don't want to make eye contact with this person because they're frightening me or because I don't like them or whatever. And I've had people say, oh, okay, Robert, when you go to New York, don't make eye contact with anybody because you never know what's going to happen. I don't agree with that. I think we should use our eye contact to build the good communication and to convey what we're wanting. That is part of body language. Exit strategy. Department of Homeland Security says we should always know where at least 2 exits are at wherever we go. This is where the stay safe methods dovetail just as strongly into, say, how to manage an active shooter situation. We should always know how to exit wherever we're at, whether it's in our workplace, a religious institution, an educational institution, a shopping mall. It doesn't matter. We should always have an exit strategy, whether it's a patient room or wherever. We should always keep our mind on how we can get out of the scene because that's a major way to stay safe. Let me conclude with the watching of the hands. Again, I cannot say enough about just how important this is. It's with hands that most people hurt other people. Whether they punch us or they hold the stick or the pipe to hit us with, or they hold the belt, the chain, the rope to tie us up with, or whether they hold the knife, the needle, the broken piece of glass to cut us with, or whether they hold the firearm to shoot us with. It's with hands in any society that people tend to hurt other people. Keeping an awareness of people's hands is very valuable. When you notice people doing something that gives you a gut twitch where they're reaching in deep into a pocket, or they're reaching into a bag, or they seem to be hiding something or reaching for something in some odd way, act on it. This is where it connects with exit strategy. If it gives you a bad feeling, leave the area. So again, these are simply some major pillars of managing safety. Okay, Dr. Pickett, do we have time to do any of the case studies?
It's just about 9 o'clock, so I think we probably don't have time to go through the cases, which we'd be delighted to come back a different time. But the one I was able to actually finally open up the chat, and it's an excellent question of how do we think about if patients make specific requests to us that a particular race, gender, ethnicity of a person care for them. So throughout our Duke Health, actually I would say at our hospital, but throughout Duke Health, we do not change who's caring for a patient, but we explain that clearly that we will have the best person care for them at that time. Now, there are always extenuating circumstances, and I think about a person who's been physically assaulted by, a woman who's been physically assaulted by a man and perhaps trying to arrange care in the acute setting, if that can be done. But you cannot choose the gender or race of person who cares for you. And so we will stand behind that. Again, being communicated with dignity and respect to the person making the request and trying to seek to understand their reasoning for asking that request. The next thing I really want to do is while before we sign off, one thing that's really important, because Robert said this, like call for help. And I work in the surgical ICU. We work with victims of violence like every single day. And so we unfortunately tend to call in Robert's team, who are extremely responsive to us. how do you get that help? So most of us don't go to the house phones anymore, because if you go to the house phone and dial 911, you go straight to someone straight to someone from Duke who can figure out where you are and deploy someone to help you there. If you call from 911 from your cell phone, that person doesn't necessarily know you're at Duke, and it goes to kind of regular 911. And I'm sure Robert can say this better than I do. So, but two things you need to know are, if you're using a yellow phone, so the bat phones that the nurses carry, and sometimes our providers do as well, those phones are still Duke phones. And if you dial 911, you get to the Duke dispatch. And that is helpful to you. So if you have a choice to call from one of those phones, that goes directly to someone who can immediately send help from Robert's team to you. They don't know where you are, so you're going to have to tell them where you are, but it will deploy help. If you've just got your cell phone and you dial 911, you'll get help, but it's not Duke specific. So if you go into your cell phone right now and either label it help, Duke security, whatever, the 919-684-2444, then you can just hit that number, and that's the same as dialing 911 from our phones in the hospital. And that gets you immediate help. So if I can ask you to take anything away from this today, make sure that you're safe and you know how to get help the most expeditiously, because sometimes we all need help for whatever reason, and that would be available to you. Robert, do you have any other comments on that? I'm sure you say it better than I would.
Actually, I think you said that perfectly. You can dial 911 from a Duke landline or the yellow phones, and it will go directly to the Duke Police Department Communications Dispatch 911 operator. So that's important to know. And for anyone with more administrative needs, like let's say there's an appointment coming up and you want help with managing that appointment, you could call the 684-2444 number, and they will connect you with hopefully me or someone appropriate.
So I think that the final summary is really that we want you to know that we are here proactively, just as we plan for caring for patients' blood pressure control, just as we plan for having our floors not be wet and places that people can slip and fall and harm themselves. We have proactive plans to keep our team members safe by addressing behavioral issues proactively as often as possible, de-escalating in the moment if proactive has not been possible or effective, and then a way to contact security if you need help in the moment. So this should be something that you talk about on rounds. If you have a patient that's displaying disruptive behavior, just as you talk about their physical exam, you should talk about the plan of care for their emotional, their violent behavior, their bad language that they use with you, which we think is equally important to address, so that we can set expectations with our families and our patients to keep you emotionally and physically safe so you can do your best job every day when you come to Duke Hospital to provide care. So really appreciate the opportunity to come and talk with you, and happy to address any other questions.
Thank you, guys. We really appreciate your time.
Awesome. Great. Well, I hope you all have a really good day and stay safe and well.
Thank you.
Get vaccinated.
Thank you, everyone.
Robert. Yeah.
Thank you.
Stay safe.
All right. Have a great day.
Bye-bye.